It gives me an immense pleasure to introduce him as the first speaker. Am I audible to everybody?
Yes, yes.
Yes, you are audible.
Currently, Currently, he's the director of Sudhir Diagnostics, and he has a lot of work in. He's done a lot of work in breast, thyroid, and OBGYN imaging, and he has a lot of presentations as well. And he has been invited as a guest speaker at various national and IRA conferences. His keen areas of interest are obstetrics and musculoskeletal ultrasound, elastography, and Doppler studies. He has an extremely notable achievements in the field of IMA and has been felicitated by National Award on IMA in the News Bulletin. So with these words, I would request Dr. Sudhir to kindly proceed with his talk, which is on fetal renal anomalies. Dr. Sudhir, please.
Good afternoon, ma'am.
So slides open.
I share this.
Share the screen.
Good afternoon, ma'am. Thank you very much for kind words. Today's my topic is fetal renal anomalies. I'm going to speak. The subject is very vast. I will try to quickly cover it. The fetal renal anomalies. We are using, one has to work on a higher-end machine with the multi-frequency probes, and the fetal kidney and urinary tract develops from the intermediate mesoderm, and the fetal kidney is developed in the pelvis, and it ascends to the abdomen in 6 to 9 weeks' time. In the first trimester, the fetal kidney is seen as only a screening tool, despite of growing resolutions of the machine. The fetal kidney is routinely imaged in second and third trimester. This is a 11 to 13 weeks scan when you have an abdominal scan and as well as TBS. The transvaginal scan clearly delineates the oval hyperechoic structure in the paravertebral region with a small sonolucent area due to fluid in the renal pelvis. In the early second trimester, they appear as isoic to hypoechoic structure adjacent to the spine. And as the fetus matures, it becomes better delineated because of the fat deposition in the perinephric and renal sinus region. Better seen in 16 to 18 weeks of gestational age. After 17 to 18 weeks, it is possible to recognize some structure, but 20 weeks, the sonographic architecture of the kidney is quite clear. The kidney grows throughout the pregnancy, and as the pregnancy advances, we see a better visualization of the kidney. In third trimester, we can see the renal pyramids, corticomedullary distinctions becomes apparent, and it is normal fetal lobulations are visible. This is almost an adult kidney. Third trimester is almost like an adult kidney. You can see the renal capsule, cortex, medulla, and you can see the renal sinuses. So kidney grows throughout the pregnancy, and there is a rule of thumb. The millimeter in length is almost equal to that of gestational age, 20 weeks and thereafter. So in 20 weeks, the kidney length is 20 mm, and thereafter 1.1 mm every week till the 40 weeks. The ratio of renal to abdominal circumference remains constant, 0.27 to 0.30 throughout the pregnancy. The calyces are not visualized, but it is usual to see some fluid in the pelvis. The normal ureters are not seen. Until unless they are dilated, they are not seen. The fetal bladder can be visualized from the first trimester in about 80% of the fetus at around 11 weeks, and more than 90% by 13 weeks. To delineate the bladder more clearly and more distinctly, we can put an Doppler. We can see both the umbilical arteries, and it helps in identifying the bladder, and it differentiates it from the other cystic structures. The normal bladder fills and empties approximately every 25 minutes. The renal functions are the amniotic fluid volume and fetal bladder is very important to assess the renal functions. And if the fetal urinary bladder is seen, it clearly indicates the presence of at least one functioning kidney. The amniotic fluid after 16 weeks is totally dependent on the fetal urine production. The huge list of fetal renal anomalies are there. Certain structures like renal size, renal agenesis, compensatory hypertrophy, renal pelvic dilatation, PUJ obstruction, vesico-ureteric reflux, duplication anomalies, megacystis, and posterior urethral wall, dysplastic kidneys, simple renal cysts, echogenic kidneys, renal morphological and positional anomalies, and renal tumor and renal vein thrombosis. I will try to cover up very quickly. The renal size can be small, can be large, and sometimes this and this is the nomogram, which clearly which helps in the guiding to with a small finding out labeling the small kidney and large kidney. This is an AP transverse and lengthwise. So we can take the help of nomograms to assess this. The small kidneys are difficult to assess. The small kidneys are difficult to evaluate an ultrasound. And renal hypoplasia, we have a differential diagnosis like dysplastic kidneys and growth restricted fetus and ectopic location in the pelvis and genetically small kidney. The small kidneys can be only small in size, but otherwise can be abnormal. The enlarged kidneys, the following points should be seen in the evaluating enlarged kidneys. We have to see is the processes on both sides. One side, are there any associated anomalies? Amniotic fluid is normal, abnormal. Are the kidneys are more echogenic? How significant is the enlargement? Is the collecting system normal? Are there any cystic changes, unilateral or bilateral? And is the bladder identified normal in appearances? The small kidneys, large, kidneys can be large and kidneys can be absent, sometimes renal agenesis. When we are scanning obstetric ultrasound reading after 16 weeks and we are getting a severe oligohydramnios and lack of visualization of the bladder is there. So we have to look for the kidneys in the renal fossa and ectopic locations. And we don't find the kidneys in the renal fossa and ectopic locations. Then we have to put a Doppler to see for the renal arteries. The bilateral renal agenesis, if the severe oligohydramnios is there, bladder is not visualized. Usually you have to assess both kidney, and this is a bilateral renal agenesis when the Doppler do not reveal the renal arteries. This is a unilateral renal agenesis. One kidney is seen, and putting a Doppler reveals clearly the one renal artery. Sometimes one kidney is missing, and the other kidney has to compensate for the missing kidney. It becomes enlarged, globular in appearances, and larger than what it is expected. The ratio of AP in transverse diameter changes more than 0.9 or greater, has 100% accuracy of detecting compensatory hypertrophy. When the kidneys are not seen in the renal fossa, the adrenal gets flattened and lies down. This is called lying down adrenal sign. We can clearly see in this longitudinal scan, this hypoechoic flattened adrenals are seen. And this was the case of bilateral renal agenesis, where we are getting both the adrenals are flattened. And putting a Doppler, the renal arteries are not seen. Renal pelvic dilatation, this is 1 or 5 into 500 newborn. It's very common. And outcome is good in the unilateral form. And there is a spontaneous regression in 30 to 40% of the cases. When the mild renal pelvic dilatation is seen in second trimester, it is important to follow them up and to confirm, because it is sometimes they might progress, and it is one of the minor marker for trisomy 21. So we have to confirm this is an isolated finding, or there are some markers are also present. The dilatation of renal calyceal system has been classified in this is a diagnostic criteria for renal pelvic dilatation. This can be mild, moderate, or severe in second and third trimester. And 4 to 7 and 7 to 10 and above 10 is severe in the second trimester. 7 to 9, 9 to 15 and above 15 is in the third trimester. But there is another classification and a fetal urological grading system which reveals the kidney. Grade 0 is normal, absolutely. Grade 1, you're getting a renal pelvic dilatation. Grade 2, you're getting dilatation and mild calyceal dilatation. Grade 3, you're getting dilated pelvis, all the calyces are dilated. And grade 4, you're getting calyceal dilatation and renal parenchymal thinning. So in this classification, the renal parenchymal thinning is there when that label is a grade 4. So pelvis and calyceal system is assessed, and the new classification is introduced. This is called UTD classification system. This came into picture in 2014, and it has a correlation between the antenatal and postnatal scan. Introduced with multidisciplinary consensus on the classification of the prenatal and postnatal urinary tract dilatation. We have to have a different, based on 6 categories on the basic ultrasound finding. We have to see anterior posterior renal pelvic diameter, AP, RPD, calyceal dilatation, renal parenchymal thickness, renal parenchymal appearances, bladder abnormalities, and ureter abnormality. The classification system is stratified based on the gestational age. So the 6 criteria point which we have already discussed, we'll see in 16 to 27 weeks fetus if the APRPD is 4 to 7, and in 28 weeks then APRPD is 7 to 10, and you're getting central or no calyceal dilatation, and there are no unexplained oligohydramnios. This is UTD A1, a low risk fetus. Then 16 to 27 weeks, then APRPD is 7 mm or above, and 28 weeks APRPD is 10 mm and above, and you're getting 10 above peripheral calyceal dilatation. You get a parenchymal thickness abnormal, parenchymal appearances abnormal, ureter abnormal, bladder abnormal, unexplained oligohydramnios there. This is the increased risk of fetus. UTD is A2, A3. And we have to correlate with the postnatal presentation. The fetus is we assess the kidney after the fetus 48 hours after the birth, and APRPD is 10 to 15 mm. You are getting central calyceal dilatation. Rest all other things are normal. Parenchyma, ureter, bladder. This is an low risk UTD P1. And after again, APRPD is above 15 mm. You're getting peripheral calyceal dilatation. Ureter is abnormal. This is an intermediate risk. This is UTD P2. And APRPD is more than 15 mm, 15 mm or more, and you're getting all abnormal features: peripheral calyceal dilatation, parenchymal thickness abnormal, parenchymal appearances abnormal, ureter is abnormal, bladder is abnormal. This is a high risk UTD P3. So we have to assess, this classification is recent, and we have to assess perinatal and postnatal presentation. So it helps in finding out the low and high risk fetus, and it helps in the management. So this is the recent classification event. It came in 2014. The POJ obstruction is more 1 in 2000 births, more common in males, and most common cause of the neonatal hydronephrosis. Most cases are functional, muscular abnormalities because of caused by. Another cause is fixed anatomical lesions like fibrous sedations, kinks, walls, and aberrant vessels. And you get in a sonography, you'll get a dilated renal pelvis with or without cholestasis. The amniotic fluid is traditionally normal until unless it is associated with some other problem. And in certain cases, because of back pressure changes, there is an encapsulated collection of urine due to tear in the pelvis or calyx, and you get a perinephric urinoma and urinary ascites. Vesicouretic reflux occurs when there is abnormal insertion of the ureter and into the urinary bladder. It can be unilateral or bilateral. The ultrasound might reveal the mild, non-progressive, or sometimes the intermittent hydronephrosis. And the kidneys can be normal in vesicouretic reflux. And we have to assess the fetus after it is born, and postnatal VCU might reveal the left vesicouretic reflux. Duplicating collecting system is more common in female. This is the anomaly which is common in female. 1 in 4,000 pregnancy, often unilateral. The kidney contains two distinct renal pelvis, upper moiety and lower moiety, with an intervening band of renal tissue. There is an often dilatation of upper pole ureter accompanied by ureter seal within the bladder. So you can have two distinct renal pelvis with an intervening band of renal tissue. The upper moiety of pelvis is an upper pole of ureter is usually accompanied by an ureter seal, but ureter seal may be there and may not be there. But there are other variants of the duplicate collecting system. The megacystis, this is refers to presence of unusually large bladder, and because it is an association with the renal anomalies, posterior third wall, and poor prune belly syndrome we are just discussing here. The posterior third wall, the fetal lower urinary tract obstruction, and this is the second most common cause of the hydronephrosis. You are getting a dilated bladder, and you are getting a keyhole sign which is often clearly seen, and bilateral hydronephrosis. The amniotic fluid may be, amniotic fluid is usually oligohydramnios seen. This is a syndrome which you are just mentioning. You get with the posterior third wall, you get a dilated bladder and undescended testis, and lack of musculature gives the abdominal wall a flaccid wrinkle appearance. Then dysplastic kidneys. Porter classification of renal dysplasia, autosomal recessive polycystic kidney disease, multicystic dysplastic kidney disease, autosomal dominant polycystic kidney disease, and obstructive cystic dysplasia. The autosomal recessive polycystic kidney, this is Porter type 1. The ultrasound diagnosis is you get a kidney extremely enlarged to fill the entire abdominal wall, and the kidney, the abdominal is hyperechoic, and bladder is not seen, and there is a severe oligohydramnios after 16 weeks. And the outcome is not favorable due to renal failure, and you get a pulmonary hypoplasia, and the Porter sequence where you're getting renal fetal faces and deformities of the limbs. So this is an autosomal recessive polycystic kidney. Sometimes you have to differentiate with the autosomal dominant variety, autosomal dominant polycystic kidney disease. This is Porter type 3. 1 in 1,000 people, both kidneys are moderately increased in volume. You're getting corticomedullary differentiation increase. The bladder is visualized, the amniotic fluid is normal, and positive family history is present. And it reveals the doubt when there is a confusion, parent's kidney can be examined. And you have to differentiate it with, as I told you, the recessive variety, and we can clearly, it manifests in 3rd to 5th decade of life. The prenatal period prognosis is not good. Then another syndrome, sometimes the polycystic kidneys are associated with some other more problems, and you can get an polydactyly, genital anomalies, and this is called Bardet-Biedl syndrome, and you can get an extra fingers and retinitis pigmentosa. There is another one syndrome which is associated with polycystic kidney, which we are going to talk here, is an Meckel-Kruger syndrome. You are getting an polycystic kidney, cephalocele, microcephaly, and polydactyly. Then we are going to talk about multicystic dysplastic kidney. This is MCDK Potter type 2, usually unilateral in 75 to 80% of cases. When is a good prognosis, and usually when it is unilateral, the prognosis is good, and bilateral is unfavorable prognosis. You are getting the affected kidney is usually increase in volume. You are seeing the multiple non-communicating cysts of variable sizes. The parenchyma is hyperechoic, residual parenchyma, and you have to differentiate sometimes with the hydronephrosis, where you're getting a communicating anechoic areas in the hydronephrosis, and the renal parenchyma is usually normal in the simple hydronephrosis when it is not associated with other problems. Then obstructive cystic dysplasia, Potter type 4. It is the kidneys are normal or reduced in dimensions. Hyperechoic, you are getting a multiple cortical areas in the cystic area in the cortex, and the features of obstruction is there. And outcome is in isolated form is depends on the outcome depends on the severity of obstruction and extent of dysplasia. Simple renal cyst is not very common, but not unknown also. You can see sometimes simple renal cyst, but and you have to follow them up because may early evidence of a dysplastic kidney. Then echogenic kidneys, you get a bright kidneys, and you have to look for other anomalies. And when other malformations are detected, serotyping may indicate to exclude the aneuploidy, usually trisomy 13. And this is a huge list. Differential diagnosis is there. You have to assess what it is. Renal morphology and positional anomaly. This is a pelvic kidney. Simple renal ectopia. 1 in 2000. And outcome is good when isolated. And it fails to migrate upwards, mostly hypoplastic, and have an atypical blood supply, abnormally shaped. Cross renal ectopia, incident in 1 in 7,500, when both the kidneys are located at the same site. The other side, you don't get a kidney, and you find the kidney on the same side. Both the kidneys are there. When it is fused, it is called cross-fused renal ectopia, and ureter of the displaced kidney open to the opposite side of the bladder. In this case, this is a third trimester ultrasound which is showing a fused kidney, and it's clearly delineating the two renal pathways. There was one case when one kidney was missing, the other side there is a large lobulated kidney was there, so giving an appearance of single large kidney. And we put the Doppler, and it showed two distinct renal arteries, and helping us to conclude that it is cross-fused renal ectopia. There are 6 subtypes, different shape and fusion, which we cannot discuss here. The HER2 kidney is 1 to 400 Watts. The fusion of lower pole of the kidney with the stomach that crosses the midline and making a U-shape shape of horseshoe is a classical sign, associated with chromosomal abnormalities. In 30% cases of Turner syndrome, and in 20% of trisomy 18, it is associated. Renal tumors is rare anomaly. The outcome is usually good. It's a mesoblastic nephroma. Renal hematoma is the most frequent renal tumors. The Wilms tumor is extremely rare, and what ultrasound finding is the diagnosis is usually made in 3rd trimester, getting a solitary mass replacing a normal kidney almost.
Dr. Sudhir?
Yeah, I'll just quickly finish.
Yeah, we are left with 2 minutes. Yeah.
Yeah, polyhydramnios is there. in such cases, in these cases, and it is uh, because of these tumors, there is hypercalcemia is there, polyuria is there, the polyhydramnios is there. The mass is sharply circumscribed, and putting a Doppler reveals an rich and atypical vascularization. You have to differentiate with the adrenal lesions. The adrenal lesion or tumor is hypoechoic and which compresses the renal parenchyma, whereas the renal masses, they replaces the renal parenchyma, and tumor is weakly hyperechoic. This is an MR. Sometimes you take the help of MR to differentiate between renal and adrenal masses. And here the picture clearly delineating, and normal renal tissue is seen. This is an MR finding. This is another syndrome which is very rare, but we are just mentioning is Beckwith-Wiedenstrom syndrome. It is associated with nephroblastoma, polycystic kidney, macroglossia, and amphilocy. There are many syndromes are there which we cannot discuss. The time is less. Sometimes you get a unilateral enlarged kidneys, echogenic kidneys, and if you see in the B mode and you are able to see some thrombus in the renal vein which is extending to IVC, is a renal thrombosis, renal vein thrombosis. I have not come across with the case. I have borrowed this slide, and this is a unilateral echogenic, one of the cause of unilateral enlarged kidney. Then what is the message we have to take home message only the scan kidney in the first trimester, measure length even if you are not suspecting any abnormality. Large kidney with increased echogenicity needs follow-up for cystic changes. Look for renal arteries and assess urine and urinary bladder and amniotic fluid. Urine and urinary bladder and amniotic fluid, they are the good indicator of renal function. Postnatal follow-up is necessary. Many times we find something in the antenatal scan and postnatal scan reveals something else. So we have to do a follow-up in all cases. Postnatal follow-up is necessary. These are the references I have used in helping me. This has helped me preparing this talk. And I want to thank the organizing committee and especially Dr. Sudhir Gokhale, Dr. Bhupesh Ahuja, and all other members for giving me an opportunity to speak. And thank you very much for all who have joined this session for their listening and encouragement. Thank you. Thank you very much.
Thank you, Dr. Sudhir.
Yeah.
If there are a few questions, you can look into your chat box in the quiz session. Click on to the question answers. Yeah. Are you able to view them, sir?
No, I'm just going to say.
I think it is best to let the speakers check the chat box and answer in the chat box. Let's not waste time.
Okay.
Yes.
Okay. So over to Dr. Alka now. Can we have the introductory slide of Dr. Chandar Lula, please?
मैम सर का मेरे पास नहीं आया था सीडी.
Okay, no problem. Well, Dr. Chandar Lula needs